Hello and welcome everyone to this week's Croí Connect series, and we're delighted to have Professor Sean Dinneen joining us. Professor Dinneen is a consultant endocrinologist and is the national lead for the diabetes clinical programme in Ireland, and he's also a lecturer in medicine at NUI Galway. Thank you for joining us, Sean.
I'm delighted to participate, Irene. Thank you for the invitation.
Great. So we have lots of questions, so we might just get straight in. So just to begin with, many of our questions have come from people with both type 1 and type 2 diabetes. And perhaps to help set the scene for today's session, it would be great if you could give us a brief explanation as to what diabetes is and perhaps the difference between the two types of diabetes.
Yes. Patients with diabetes generally are differentiated by these two types, type 1 and type 2. I suppose the classical patient with type 1 diabetes is usually young when they're first diagnosed. So childhood or adolescence would be the typical time of onset of type 1 diabetes. And the other characteristic that distinguishes them is that they need insulin from day one. So their body has stopped producing insulin and they need insulin injections as their only treatment. People with type 2 diabetes typically are older and usually have other conditions like perhaps high blood pressure, lipid, fats in the blood problems, and in particular problems with their weight. And they're usually managed with non-insulin treatment, either tablets or non-insulin injectables. So they're the two kind of classical examples. What's happened in the past 10 or 15 years or more is that we're learning more about the different forms of diabetes, and those extremes, we're recognizing that type 1 diabetes can actually occur at any age, and I've seen patients diagnosed with type 1 in their 50s, 60s or older. And the other thing that's happening is that type 2 diabetes, which used to be over 40, maybe even over 50, we're actually seeing that now with the rise in the prevalence of obesity in the Western world. We're seeing it at much younger age. So it's actually it can be quite tricky. But the thing that distinguishes people with any form of diabetes is high blood sugars. If they're not treated, they tend to get symptoms of thirst and peeing a lot, and that's in the short term. In the longer term, the other thing that's common to both forms of diabetes is that the high blood sugars can lead to problems with the eyes, the kidneys, the feet, the heart, and so on. So the so-called complications of diabetes are common to both forms.
Great, Sean. Thank you for that. Sean, just given the current times we're living in, are diabetes patients more at risk of COVID-19 and should they cocoon? This is a query we had in from an individual in Donegal. And I know certainly in the last couple of weeks with the recent figures that have been released from the Department of Health, we're seeing that about 23% of admissions to ICU have underlying diabetes. So, I think certainly there are probably some concerns among people living with this condition out there.
Yes, and I mean, the answer is, it's not as straightforward a question as it might sound. And the way I would answer it is in two parts, is that people with diabetes, particularly if their blood sugars are not under good control, or if they're not running, good levels of blood sugar, they do appear to be at increased risk of worse outcomes if they get the infection. So I think that's actually, that's clear now from other parts of the world. Originally, the Chinese data, more recently the US, UK, and even, as you say, ourselves. So people with diabetes appear to have a worse outcome from the infection. Whether people with diabetes are at increased risk of developing the virus and developing COVID-19 infection is harder to say. People with diabetes, again, if their blood sugars are not well controlled, tend to be at increased risk of infection in general. So we've all been, assuming that that people with diabetes are at increased risk of developing COVID-19. And the second part of the question, should people with diabetes cocoon, is a difficult one, because We get that question a lot in our diabetes center. The advice that we generally give is, it's important for all of us. The only weapon we have against this virus is hand washing and, social distancing and all the things that we're familiar with now, cough etiquette and so on. Those things are important for all of us. I think they're especially important for people with so-called, underlying conditions, and diabetes is certainly one of those. So I think that's how I would frame it. I don't think you need to cocoon, but I think you need to be even more conscious than the rest of us about the importance of taking measures, to avoid getting or transmitting the infection.
Yeah, that sounds like very good advice, Sean. From your clinical practice and obviously with your national remit, how is COVID impacting on diabetes services at the moment across the board?
I mean, I'm glad you asked that question, because it has, for us as a national program, trying to advise and advocate for, the answer is it's had a massive impact. I mean, COVID, the response, as we all know, the response both in terms of societal impact and especially in terms of our health service, we have been, we've had to focus on the virus and the response to the pandemic. But what's happened as a result of that is, I think, two main things that I would highlight. One is redeployment of staff. So in our diabetes center here in Galway, we have lost a lot of our diabetes nurses, our clinic nurses, our admin staff are kind of working differently. Our doctors, myself, I'm doing this interview in scrubs. As an endocrinologist, I'm not usually in scrubs. So I'm in the sort of acute medicine front line, as it were. So we've had a huge, impact from redeployment of staff into the pandemic response. I would say one group in particular here in Galway are podiatrists. We've lost 12 out of 14 podiatrists working in our community healthcare organization, CHO2. And I think that's really a concern. And we've highlighted that to Colm Henry and the people running the health service. The other issue that I think is really has had a big impact here is that our patients with diabetes are afraid to come to hospital. And this isn't just true for people with diabetes, it's true for people with lots of chronic disease. And I think the next phase of this is going to be about redeploying, if that's a word, returning staff who have been redeployed to the pandemic back to their day jobs. And I think the other huge issue, and that's why podcasts or sessions like this are really, we have to help our patients, our general public, but especially our patients with chronic illness, realize that hospitals are not unsafe places to come to. If you have an appointment, you need to come. Now, we have, as a group in Galway and around the country, been trying to do virtual clinics, we call them. So we're contacting patients who are due an appointment in our diabetes center by phone or by some telemedicine link. And that will probably continue, because one of the things we've learned is that actually that's quite useful. And our young adults, for example, value it in terms of, not necessarily having to come to the hospital on a specific day, but we can call them. But I think, redeployment of staff and fear among our patients are really the two biggest things that have impacted. We can turn one of them, hopefully, off, get staff back. The fear factor is not as easy to turn off.
I agree, Sean, because I think it's similar here in Croí, and we see this in relation to, stroke services and cardiology as a whole, that people are worried, and, we're running a telephone helpline at the moment. And the biggest thing we hear is people do not want to be bothering their GP. They do not want to be bothering the hospital services, but they're also worried for themselves, that they're putting themselves at risk. So, in terms of coming forward. So I think, we're hearing this time and time again. So I think it's good to hear, the reassurances that you're offering. And as we see, services gradually resume to normal and staff come back to the centres, that hopefully, we can continue to move on and support people in living with, chronic conditions like diabetes.
We have to, Irene. Yeah, it's going to be with us for a long time by the sound.
Yeah, and I think some of the next few questions that we've received allude somewhat to some of these concerns. So one of our Croí volunteers wrote to us and said that he's 50 years old, has had diabetes for many years. His annual retinal screening has been cancelled and he's concerned that his eyesight is worsening. What should he do in this situation, Sean?
Yeah, it's a good question. And one of the services, I didn't list the services that have been impacted in terms of the previous question, but retinal screening is on hold, as are other screening services like, like breast check and so on. And I don't envy the people who have to make these decisions about turning off or turning on, but I think in the next while, these services are going to, resume. When they resume, there's going to be at least a 2-month backlog. So, the gentleman, if it is a man who asked that question, may have to wait a little while. But Retina Screen is a really, really well-organized service. They have a very good handle on their population of patients that they call, for annual screening. So I would be confident that he will have. The one thing I would say, linked to what we discussed just now around fear, if a person with diabetes who knows they have perhaps, retinopathy is the term we use for damage to the back of the eye. If you get symptoms, if you get new vision symptoms, you need to contact, the eye clinic, or you need to get your GP to contact the eye clinic. So if this person does not have, symptoms relating to his vision, I think he should sit tight and he will be called. But, if he does have symptoms, I think he should let his GP know and probably, get seen in the eye clinic.
Very good. Next question. Due to COVID-19 restrictions, I've not attended my GP to get my bloods. I'm newly diagnosed with type 2 diabetes and don't know if I'm managing my condition as good as I should. Should I be waiting until the restrictions are lifted? This is from Gemma in Sligo.
Yeah, again, a very good question. And, I'm a hospital doctor and I'm thinking of the impact on hospital practice. But of course, it has also had a huge impact. The virus and the pandemic has had a huge impact on community services and general practice. So I would say that, if Gemma is doing well, I'm guessing that she's been started on some medication. She's probably had some advice around diet and exercise, and which would be the mainstays of managing type 2 diabetes. If those symptoms that perhaps that she had when she was first diagnosed, if they've settled, again, I think she's doing well, and she may or may not have the ability to monitor her blood sugar. We don't recommend that for everybody with newly diagnosed type 2, but if she does, and if those blood sugars are in good order, again, I think that is encouraging. Again, a bit like hospital services will have to return to normal. General practice services will have to return to normal. And I think, she doesn't want to be bothering her. Is that right?
Yeah.
I wouldn't look at it as bothering the GP. I think, call the practice, speak to the GP, the practice nurse. They are busy. But again, like I said, the next phase of this whole response in Ireland is about bringing people along, and returning to some kind of normality. And so a blood test called the HbA1c, which we recommend, every few months for a person with diabetes, is a very good indicator of how well blood sugars are controlled. And that should probably be done, by Gemma's GP in the next, few, it doesn't have to be the next few days, it could be the next few weeks or even, next month.
Yeah, I think what was interesting, it was a very good question, and I think what's interesting from this person's perspective is the fact that they're saying, I'm not sure, I don't know if I'm managing my condition, but I think one of the things that we're noticing, and maybe this is a positive to come from this pandemic, is that people are certainly becoming hopefully more empowered, that they need to own their own conditions, so
I would agree.
That's very positive.
Absolutely, yeah. This whole idea of, I'm a diabetes specialist, but I see an individual patient, a couple of times a year, maximum maybe 3 or 4 times a year. Think of the amount of time that person is looking at, they're looking after it themselves for the vast majority of time. So I think, a big part of managing diabetes well is having the confidence to do the things that need to be done, day to day.
Okay. Sean, if somebody living with diabetes was to contract COVID-19, what changes might they expect in their blood glucose levels?
Yeah, so generally, people with diabetes who get an infection, particularly if it's a more severe infection. Now, again, not everybody with diabetes will necessarily have severe impact from the virus, but oftentimes blood glucose levels are a good indicator. In other words, they will go up. It's like a stress response. Importantly, particularly for people with type 1 diabetes who are dependent on insulin for treatment, they can, if they get a severe infection, as well as getting high blood glucose levels, high blood sugars, they can also get what we call ketones in the blood and in the urine. So this is an indicator of, I suppose, an additional stress level over and above, high blood sugars result from the stress of the infection, but spilling ketones in the blood or in the urine. And a lot of patients with type 1 diabetes would be familiar with monitoring for ketones on what we call sick days. So the answer, I think, is blood sugars are likely to go up. If it's a mild dose of the virus, and 80+% of people get a mild dose, they may not notice too much. But if it does have an impact, it's likely that it will lead to high blood sugars. And then what we call sick day rules, should be used to sort of monitor a bit more frequently, keep yourself well hydrated, check for ketones. And importantly, again, the kind of recurring theme of this interview is contact the services if you need help,
Sure. And should everybody living with diabetes be if they're unwell, should they be checking their ketones?
That's a good question. I mean, certainly people with type 1 diabetes are generally instructed in monitoring for ketones. Nowadays, more often in the blood. It used to be in the urine, but nowadays, we'd have ketone meters. People with type 2 diabetes, in the past, we generally have not recommended it routinely, but there is one class of drug that is relatively new. They're called, the name of them is SGLT2 inhibitors, and they usually end in flozin, so dapagliflozin, a drug called Forxiga, or empagliflozin, a drug called Jardiance. What we have noticed in the time that these drugs have been used is that they can actually lead to ketones, spilling in the blood or in the urine when a person is unwell. So we are now in Galway and in a lot of hospitals around the country, when we see people coming in, people with type 2 diabetes on these tablets, we're tending to stop them routinely because of this risk of developing what we call DKA, or diabetic ketoacidosis. So that's, I think, not everybody who gets the virus will get a severe dose. But if you do, I think monitoring blood, monitoring ketones, and if you're not familiar with monitoring ketones, it's probably worth contacting, again, your GP or the hospital team if you're linked up with them.
Yeah, very good. And we did actually, in fact, get a question about those medications, the SGLT2 medications, in terms of they'd heard about them being stopped in some patients. So I'm glad you've mentioned that, Sean, and clarified that. So I suppose just in general, obviously, there are a lot of concerns that people have around, living with diabetes in the current COVID situation. But I suppose, how best do you think we could support people in living with diabetes manage their condition at this moment in time? I know the GP is a good port to call, and obviously your clinics as well.
Yes, and and I think more importantly, and you talked earlier, Irene, about some positives coming out of this pandemic. I think one of the things that I think we've all appreciated is this sense of looking after each other and our mental health. I think there's a lot of worry out there, and particularly, if you have an underlying condition like diabetes. And so I think, being kind to each other, reaching out, helping people, asking people, how are you getting on? In the diabetes context, I sent you a link, and maybe you'll share it with the people online. But as part of our national program, we were asked to put some guidance together for people with diabetes during the pandemic, and we came across a very interesting website which is talking about mental health more so than diabetes health or, you know, blood sugar control. And I found it personally, actually, I found it very, you know, empowering. It's talking about the simple stuff, you know, eating well, sleeping well, trying not to listen to every single news bulletin, which, you know, will drive you stats, you know, and just taking time out from the whole thing, spending time with, you know, the people you love and all that kind of stuff, which is important anyway, but I think it's especially important at the moment that we look after ourselves. So keeping in contact with your diabetes team, whether it's your general practitioner, practice nurse, diabetes team in the hospital, but also just looking after yourself.
Yeah, and I think, you know, Sean, we can certainly make that link available to people, because I think the advice from the HSE throughout this pandemic has been excellent. So it's very good for people to know reputable sources of information that they can go to, because you hear a lot in the media, and to be fair, sometimes you do have to tune out. So, you know, reputable source of information and you know, knowing the fact from the fiction, I think is really very important at this time. Now, we've been talking about diabetes, and obviously this is the Croí Connects series. And from time to time, people don't often associate diabetes with cardiovascular disease, but how big of a cardiovascular risk factor is diabetes?
Yes, so it's one of the big risk factors, I suppose, if you were to list them, you know, high blood pressure, cigarette smoking, you know, diabetes, obesity. So I would say that, yeah, people with diabetes are at increased risk of having coronary artery disease or, you know, so heart attack, stroke. We cannot get rid of the diabetes, but we can do things to reduce a person's risk of having a heart attack in the future. And there are some things like, you know, taking a statin, for example, you know, when you get to a certain age living with diabetes, it might be younger perhaps than if you didn't have diabetes. If you are a smoker, trying to put the cigarettes aside, you know, it's important for anybody, but I think especially important for a person with diabetes. And then managing the blood sugar and the blood pressure, you know, well. So those things can offset the risk, but there is definitely an increased risk of, you know, coronary disease or cardiovascular disease when you live with diabetes, and we can mitigate some of that risk, but we can't get rid of it all.
Sure. And do you think people who are being treated for diabetes fully understand or appreciate that risk? And, you know, what do you feel is the best way to communicate the risk?
Yeah, that's a good question. Again, I suppose podcasts like this one that we're doing here today, highlighting the you know, the association for people living with diabetes. I think, you know, communicating the risk without, it's about being informed but not being scared. You know, and I would say that, yeah, just the whole cardiovascular health, you know, trust which Croí, certainly in the west of Ireland, has led out on, you know, is probably where that education comes from, Irene. And you know, right from the outset, being aware that, yeah, you probably do need, when you have type 2 diabetes in particular, or long-standing type 1 diabetes, you know, you probably do need to be on a statin or on a blood pressure, you know, lowering agent if your blood pressure is even moderately high.
Yeah, and I think there's, you know, also, again, going back to the positives, that, you know, many of the lifestyle changes that we recommend for diabetes also reduce one's risk of developing, you know, heart disease or stroke as well. So I think sometimes maybe it's about, you know, communicating these messages and making them easy to understand for the individual. I was recently started on metformin for type 2 diabetes and have been experiencing stomach upset. I don't want to hassle my GP as she's so busy. Should I stop taking my medication? So again, I know we're back to linking in with the GP and some of the fear that's out there.
Yeah, and I would, you know, without sounding like a scratch record, I would say it's not a hassle. You know, that's the GP. The GP, I think, would much rather have that discussion with that person than find out, 2 or 3 months from now that their blood sugar control has gone off because they stopped the metformin. How we introduce metformin can make a difference. It does tend to upset the tummy, but if we go gradually with the drug, introduce it in a low dose, build it up, let the body kind of get used to it, then it's a very, very good medicine, and it's usually the first drug we recommend. So I would not be inclined to stop it. If I was advising that patient, I would 100% be inclined to contact the GP, and I don't think they're hassling the GP with that phone call.
Great. One of the last questions, Sean, that we've received in, and it's quite a big question, and it's, can you cure diabetes? This is from Michael in Limerick. It's a very good question.
Yeah, and I would say that, for people with type 1 diabetes, the cure has been talked about, for a long time, and I've been working in diabetes care now for a good few years, and I've seen huge advances in that time, especially in the technology. So we have, most people still check blood sugar by a finger prick, a little drop of blood put on a strip. We're now getting to a point where either on the arm or on the tummy, we can place what are called sensors. They're sensing glucose continuously for up to 2 weeks. And that's real, and that can feed to a person's phone or, to a reader, and tell them pretty much what's happening with their blood sugar 24/7. We generally, with people with type 1 diabetes, give insulin by using a pen, an insulin pen. But again, this technology has advanced where pumps are becoming much more commonly available now, and these are sophisticated little devices about the size of a mobile phone that can give insulin in very, very small amounts, or dialing up or dialing down the amount. What's incredible is that in the last 5 or 10 years, the technology has got to a point where the sensor is able to talk to the pump. Now, you could argue, and the terminology here is artificial pancreas, people are calling it. And that's phenomenal. You have devices attached to you, so is it a cure, or is it just being attached to devices all the time? Maybe people might view it differently, but the technology has advanced incredibly. Immunotherapy, which is the damage that's done in type 1 diabetes is done by the immune system. It wipes out the beta cells that make insulin. There's a lot of work going on in trying to turn off that damage or identify it early. That hasn't been that's another potential cure, and that hasn't been as successful in terms of making progress. So the technology, I think, more than the immune therapy, is really where we've seen the benefits in the last few years. And then I suppose transplantation, either of whole pancreas, with from a donor, who has died, or from giving islets, the cells that make insulin. And again, that has been progressing, but I think probably in type 1 diabetes technology, interestingly, as recently, if you asked me that question about 5 or 10 years ago in terms of type 2, I would have said no cure and no sign of one. But now with what's called metabolic surgery, or often referred to as bariatric surgery, we've realized that if a person with type 2 diabetes has an operation on their gut to either reduce the volume of their stomach or bypass part of the gut, we see incredible results in terms of weight loss, but also losing or putting diabetes into remission. So this work has led to studies of even just very low calorie diet or low calorie diets having a similar impact. And it doesn't seem to be just the weight loss. It seems to be a reprogramming of the way that the gut talks to the brain. And there's a lot of work going on in that area trying to understand it better. So a cure for type 1, I would say, is more of a reality than it was 10 or 15 years ago. Putting type 2 diabetes into remission is probably the better term than cure, but that is also a reality. We don't do very many bariatric surgeries in Ireland, but if we did have better capacity to do them, we would see type 2 going into remission in more patients.
Great. I mean, I think it's fantastic to hear about these innovations and, particularly hearing about the sensors. How far away, Sean, do you think we are from, seeing these as part of, maybe routine care?
Yeah, I mean,
Is it imminent?
it's a good question. I think that the Medtronic is the company, one of the main companies in the States that has this closed loop or this artificial pancreas. It's available in the US. We've had at least one patient come to Ireland who has already been placed on it. And a phenomenon in the world of type 1 diabetes is this idea of looping, as it's called, where patients who are not willing to wait for the health service to make it available have figured out how to I don't want to call it hacking, although that's what it amounts to, is they get access to the programming or the kind of the coding of the pump and the sensor, and they're able to get it. I'm a little bit leery or wary of that because I don't understand the technology enough, and first do no harm is one of the diktats that we sign up to as doctors. But it does give you a sense of the patients. Some patients who are very tech savvy are not willing to wait for this to happen, and they're doing it themselves. DIY is the term that's used to describe it. DIY looping. Unbelievable that we're even having this conversation.
Yeah, it's fascinating stuff, Sean, really. But again, I think it offers much encouragement in terms of and hopefully it's very positive. The future sounds really
the way I frame it for it's often a very, very sad and stressful time for a parent if a child is diagnosed with type 1, because they feel they've burdened the offspring with this condition. I try to frame it, I say that they need to keep the child well. And in their life, if somebody was diagnosed now, age 10 or 15 or whatever, in their lifetime there will be huge advances. I'm certain of it. And in the meantime, dealing with the drudgery of the monitoring and the hassle of the diet and all the things that comes with type 1 diabetes. But it's worth it if you stay well enough to avail of these advances that are definitely coming down the track.
Super, Sean. Sean, we're nearing the end of the session, and thank you so much for joining us today. But it would be great, are there any key messages that you would like to communicate to the community, and particularly those living with diabetes?
Yeah, so one parting comment. Retina screen, I mentioned it earlier, they're aware of about 170,000 people living with diabetes in Ireland, because they have for about 3 or 4 years now been tracking and calling people and recalling them and so on. One of the things that we really lack in Ireland in the world of chronic disease and particularly in diabetes is we do not have a diabetes register, national diabetes register. Countries that are on top of their diabetes care, like in Scandinavia, in Scotland and other parts of Europe, they know who has it. If you want to improve services or you want to improve things for for people with diabetes, the first thing you need to know is who has it. So as a national program, we've been advocating for this for some time now, and we're beginning to gain some traction. And then of course COVID comes along and we get our plans get kind of scuppered. But I would say that for people living with diabetes to be aware of the importance of us, and I say us, the health service. It's not about Big Brother or anything like that. It's just about knowing who has the condition so that we can make sure your eyes, your kidneys, your feet are checked. We have an idea of how you're managing in terms of your blood tests and so on. That's really important. And I think that for us medics to advocate for it, but also for people living with the condition to be advocating for it, I would love to see that happen in Ireland.
Yeah, no, that sounds really positive, Sean, and certainly the way we need to be going. And, particularly, when we talk about heart disease and we talk about diabetes, and I think if we want to try and integrate care, we do need to have these registers and need to be working together and advocating, because at the end of the day, we're here to support and help people living with diabetes and cardiovascular disease manage their conditions better. So that sounds like, it's an absolute necessity in terms of moving forward. Sean, thank you once again for joining us. I think you've answered all those questions really well. Hopefully offered a lot of assurance to individuals out there. I think the key message is certainly linking in with your GP, not being afraid to, to come forward, linking in with the diabetes clinics across the country, wherever you're linked to, albeit there might be staff shortages at the moment. People are returning back to their own departments, and not to feel afraid about any of this, So thank you so much for joining us. Croí Connects returns in 2 weeks' time again, and we're delighted to have Norma Caples join us. Norma has over 20 years experience working in cardiology, and the last 5 years have been very much focused in the heart failure space. And she currently works as a clinical nurse specialist and is the national nurse lead for the heart failure programs in Ireland. So it's great to have representation from the various national clinical programs. So we're looking forward to chatting with Norma. As always, please do get your questions in. You can call us on 091 544 310. Don't forget to stay tuned to our website and across all our social media channels. There's lots of great resources for you out there. And take care of yourself, and thank you for watching. Bye-bye.